So I will be talking on, I put it in the simple way that ultrasound image guided radiation therapy physics perspective, introduction to the physics of ultrasound, the basics, what most of the radiation oncology physicists are not much familiar. So just a little bit of touching that concepts. Then ultrasound imaging role in radiation therapy. Then what are the IGRT technologies based on ultrasound, and what are the requirements and the procedures what we adopted for clinically implementing the Clarity Prostate 4D ultrasound system at our institutions, how the workflow of that 4D ultrasound IGRT system, and what is the new developments. That's most important in order to understand that ultrasound, the future directions or futuristic aspects. And I will be concluding and summarizing and concluding. So this is what as a physicist, we all are not aware, not necessary to introduce, much about that, the ultrasound to this audience. However, for the sake of introductions, I would just, give the brief about the physics of sound. The sound is a vibration that propagates as an acoustic wave, nothing but pressure wave through the medium. So this acoustic or pressure wave will not, transmit through the vacuum. So the sound having the frequency that exceeds the limits of having the human hearing, exceeding the limits of human hearing is known as ultrasound. The human hearing ranges from 20 hertz to 20 kilohertz. Similarly, ultrasound ranges greater than 20 kilohertz, wherein the medical ultrasound ranges 2 to 10 megahertz or more, depends upon that, the kind of the site that, the transducer is being used. So basically, the sound wave is basically a mechanical wave which travels in straight line. It obeys the ordinary wave behavior such as reflection, refraction, and diffraction, and scattering, etc. So the sound velocity in the body on an average of 1540 meter seconds. This is that the velocity in the body and the soft tissue. So this kind of the sound-based image, if we are nothing but ultrasound imaging. So this is what all about this. So coming to this characteristic areas, when you look at that unfocused beam of ultrasound, one is called the near field or Fresnel zone. Another one is called the far field or Fraunhofer zone. The near field means the region of the convergence, the beam is defined as near beam. Basically, up to that, the focal point that the near field will be, region. And apart from that, the focal point, the divergence region is called the far field. So the axial, the near field is responsible for axial resolution, and the far field is responsible for the lateral resolutions. So if you look at that, the near field imaging and far field imaging, in the near field imaging, that the return echo will be very faster, whereas in the far field imaging, the return echo will be very slow. So this is kind of the very brief about that, the characteristics of ultrasound beam. So as we know that every the medium or material has a different density. When the sound travels or transmits through the different density, how that the speed of sound, nothing but the acoustic impedance is going to be there. So based on that different material and density, that acoustic impedance will be different, nothing but the speed of sound. If you look at that, the acoustic impedance is 0.004 into 10 power 6. Soft tissue, if you look at that, 1.6 in 10 power 6, whereas bone, if you look at that, the impedance is 7.8 into 10 power 6. So this is what the kind of the acoustic impedance characteristics for different medium or material. So what is the source? In case of an X-ray, we know that electromagnetic radiations are radionuclide imaging radioactive source, whereas in the case of ultrasound imaging, what is that, the source of the production of the source, that ultrasound waves. So that is, nothing but the transducers. Basically the transducer is, it operates based on the photoelectric principle, which we all know that the photoelectric principle basically converts the energy from one form to the another form. That means the electrical energy into the mechanical energy, which is nothing but that, the ultrasound. There are, the different, the kind of the photoelectric crystals are being used, such as quartz and ceramic, even, the lead, zirconate, titanate kind of, PZ materials are being used commonly. Basically the transducer that transmits or generates the sound waves and the transmits through the medium, again it receives back in the form of the reflection or reflective echoes. So the transducer basically controls the pulses. That means the amplitude, frequency, and durations can be manipulated by means of a transducer in order to get that, the beam, the desired the penetrability. So there are two important ways that, the superficial organ can be, imaged having, the larger frequency or a greater frequency ranging from, 7.5 to 15 megahertz to a depth of 1 to 3 centimeter. In case of the deeper structure like pelvis and abdominal, the frequency required is less, because we know that, the wavelength and frequency is inversely proportional to. So in case of the deeper structures like abdominal and, the pelvic, 12 to 15 centimeter, that and the frequency is less. So the frequency is based on the thickness of that, the crystal. In case of, the transducer is having, three different kind of, the region. One is called the tuning coil, another one is the damping plug, and piezoelectric effect and matching layers. So the piezoelectric elements is responsible for producing that, the electric, the wave, which generates the sounds when applied to the voltage. Similarly, that the photoelectric effect, that generates a voltage when applied with the vibration. That means, the ultrasonic waves. So the thinner the element, the better the resolution. That means lesser the penetrations or propagation. Thicker the element, poorer the resolutions, and greater the penetrations or propagation. So this is a basic, about the transducer. There are three type of transducers in terms of crystal arrangement, the footprint size, the frequency used, and beam shape and application. And sector transducer, linear transducer, convex transducer. So in the sector transducer, the crystal is arranged in the phased array, like the triangular kind of things. So in case of linear transducer, the crystal is arranged in the linear way, whereas in the convex transducer, the crystal is arranged in the curvilinear or convex way. So coming to the regarding the footprint size, the sector transducer is very small. In general, linear transducer and convex transducer is big, but when you use that hockey kind of transducer, it becomes small. Similarly, when you use that micro convex in the convex, it will become a small. So the frequency, if you look at that, the phased array or sector transducer uses 1 to 5 megahertz, whereas linear will use 3 to 12 megahertz, and curvilinear will use again 1 to 5 megahertz. So the beam shape will be the sector, almost a triangular shape, rectangular shape, and convex. That application is that, the small acoustic window, mainly that, the echography kind of cardiologic applications, or, other this one. Ultrasound, in case of the linear transducer, the transducer will be useful in the superficial structure, whereas in the curvilinear transducer, useful in that, very deep abdominal and pelvic structures. Yeah. So these are that, the types of, the transducer available in the market. This is linear array and phased array, convex array, and endocavity array, which will be useful for, esophagus or the transrectal probe kind of things. This is that, the latest advanced models like a 2D matrix array, or mechanically scanned the linear array, or mechanically scanned convex or curved array, intravascular array. This is for that, the cardiovascular, the application. So these are all the type of transducer in general we used. So coming to this, being that physics topic, I just wanted to touch upon about that, what are that, the mechanism involved when interacting that ultrasound with the tissues. There are two important, the interaction takes place. One is that wave, medium or matter interaction. Another one is that wave-wave interaction. The mainly that wave or tissue interactions is having four mechanisms like the reflection, refraction, attenuations, and scattering. So the reflection is nothing but when the incident beam is incident upon that, the boundary, if it is the changing its directions or redirecting, that's called the reflection. When the incident beam is the changing from that the original directions in a particular small angle, that's called the refraction. So this attenuation is nothing but absorption and scattering. Scattering is multiple the directions. The ultrasound scan or beam is ultrasound beam is generated. So if both the two different of beams having two same frequency and give that in the destructive interference. If the both frequencies are the positions are different, that it will give you that complex interference. So these are all that kind of that interactions between that the
again you are joined it. Okay, just unmute. Yeah, okay, go ahead.
So coming to this, how ultrasound image is formed. The amplitude of each reflected wave is represented by a dot. The position of the dot is again represented the depth from which the echo is received. Then the brightness of the dot represents the strength or intensity of the returning echo. The way of understanding that how that image is being formed. The strong reflection represent by means of white dots, certain areas like a pericardium, calcified structure, and a diaphragm. And the weaker reflection is represented by the gray dots, like the valve tissues and vessel walls and liver. And no reflection means block dots, like gallbladder, etc. So this is how that the image formation takes place. So coming to this, the image scanning modes. We all know that in ultrasound there are different kind of modes of the scanning is possible. Based on that echo display, we can classify as a mode ultrasound, B mode ultrasound, and M mode ultrasound. A mode ultrasound is nothing but the echo patterns display against that the function of echo amplitude function of the depth. And whereas in the B mode is an amplitude into grayscale, which will be giving that imaging that organs. And M mode means amplitude into grayscale, that is for the imaging of the organs over the time, imaging of the motion over the time. Similarly, that the Doppler mode, that is basically a fluid flow directions and velocity, basically imaging of that blood flow. There are different kind of the Doppler. One is color Doppler, power Doppler, spectral Doppler, duplex Doppler, and pulsed wave and continuous wave Doppler. There are many different type of the Doppler waves are available, and this is how that the image look like. So similarly, to understand the image quality, there are phantoms are being used to image quality phantom, wherein that we will be able to assess that what is that contrast resolution, spatial resolution, and temporal resolutions using that the phantom for validating this. There are also that the negative impact about that ultrasound is that the imaging artifacts. So there are different kind of artifacts like shadowing. That means the highly reflective objective will give you, if you look at that, the bone, underneath that bone, you can see that, the shadowing kind of things. This you have to differentiate while evaluating or interpreting the images. The shadowing, similarly, if you look at that, the low attenuation object like in a ear, block 1, you can see that, the enhancement is, different way. So similarly, the multiple reflection, that is called the reverberations effect, the speed artifact, mirroring, and twinkling. There are many different of artifacts are available or will be there, and we need to be understanding. So coming to this, before introducing the 4D ultrasound, would like to just make a introduce what is the 2D and what is 3D and 4D ultrasound based on that, the imaging modality of the dimension. So the 2D ultrasound is basically the probe sends and receives the ultrasound frequency waves in one plane. So this is what XY, the dimensions will be given for the object. And 3D ultrasound, a series of two-dimensional images are created to form a volumetric data, which is created by reflected waves at different angles. So the 2D linear transducers may be used, and high-speed computing software integrates the informations to create the 3D images. So if you look at that, the array of the data transducers are used in order to, they create that the image of 3D. You can see that, the 3D image of the baby is possible to see, look at immediately. That's what, 3D ultrasound images. Coming to this 4D is nothing but, the 3D imaging with respect to the time. That means 3D plus fourth dimension the time. And live motion of the 3D images is possible to see. Here the 3D matrix and transducer is used. The one can see that, the movement of that, the baby while, looking at scanning that, the object. So this is what that, the 4D is. So the ultrasound imaging system is having the components of different, the transducers and control panel and, the cables and display systems. You all are aware. So also we must know that what is that, the advantages and disadvantages. Why we, prefer most of the system, if you look at that. So the ultrasound is enormously, used in the medicine in different fields. So because of that, it is an excellent soft tissue contrast, especially for the prostate kind of, the anatomical structure or breast. And it is a real-time imaging. There is no invasiveness, non-invasive, no radiations, the low-cost equipment and portability. You can take this equipment to the bedside. So, however, we must also understand the limitation that in inter-observer variability, the probe pressure-induced displacement when you are, pressing, and artifact of speed of the sound aberration is possible. So these are all pros and cons. So, why, the ultrasound we are talking about. In radiation oncology, if you look at now we are talking about even quantitative imaging. So in this scenario, how that ultrasound imaging fit into this image guidance workflow of radio ultrasound also is taking place not less than the quantitative imaging, and radio mix is possible based on that quality the ultrasound imaging. So that's what of array of image guidance to imaging tools in radiation therapy. So in general, if you look at that, the ultrasound applications in brachytherapy and external beam, the transrectal ultrasound imaging is used for intraoperative needle guidance of the directional, the guidance needle as well as an applicator. This image also is being used for, the treatment planning. So when we use that intraoperative ultrasound-based, the treatment brachytherapy, you will be able to use this ultrasound imaging to plan for, the treatment dose distribution. Similarly, in the external beam, there are two methods, two ways of using that ultrasound. One is called the transabdominal ultrasound imaging, or the 3D IGRT for interfraction motion for positioning the patient's positioning verification. Another one is that the transperineal ultrasound imaging, that is for the 4D IGRT for intrafraction motion, basically the motion monitoring and estimation, real-time tumor tracking during the treatment, and also the gated therapy is possible. So this is what in general, as I told, you can see that this is the needle ultrasound. The truss ultrasound is possible to have it, and this is the treatment planning and reconstruction based on that ultrasound. This is the dose distributions in the Ancentra brachytherapy shift system used for ultrasound images in the planning. So what is actually the 3D ultrasound? As I told you, for image guided, you need to have that kind of the optical tracking system or optical system. So the probe, this is called a curvilinear probe, which is actually embedded or fixed with that infrared reflector, the passive reflector. This position of that the reflector will be captured by that the camera, infrared camera, which will be fixed in the ceiling of that the treatment room or the simulator room. So before starting that, you need to really characterize that how that the probe coordinates, room coordinates, and image coordinates are to be in the same position. And this is how that the image of this phantom, this is ultrasound calibrations in PF phantom. When you use the 3D the probe of the transabdominal ultrasound, that the different the parameter of image quality can be verified. So there are 6 or 2000 around the NOMAS batch system and the sun array system. This and another one, the latest one, Electra Clarity 3D system. So these NOMAS batch system and sun array system, it's called intra ultrasound modality. Basically, the simulator room and treatment room will have a different imaging. In case of the if you use that the NOMAS batch system and sun array, you will not have that the ultrasound system even in the simulation also. So when you use that clarity, the Electra Clarity 3D ultrasound system, you can have the two system. One is called sim system, or another one is called the treatment sim guide and treatment guide. Okay, so this is called intramodality the ultrasound guided IGRT. So there are many applications starting from that the prostate, breast, and uterus and bladder, and of course the liver is images. So what are the the technologies are available when it comes to that 4D IGRT? So what are that the aim of the 4D IGRT is to estimate the motion, to incorporate the intrafractional variations into the treatment margin. So basically there are many technologies are available. You all are aware. KVMB X-ray imaging with the fiducials, gated RT using that Novalis or an Accuray CyberKnife based on that X-ray, and variant Calypso is having that the electromagnetic transponder the system, which is again that 4D localization system. Then Vision RT and Electra Clarity and MR Linac in the recently. So if you look at that, so all that the system has some of the advantages and disadvantages. When you look at that implanted electromagnetic transponders like a Calypso system, that's a real-time tracking system, but however it is invasive. You have to make the fiducials, transponder fiducials into that the invasive, and there is a risk for the infection, and also the transponder, the fiducial migration is one of the the risky and the disadvantages. Again, it may cause that an artifact on post treatment in case of an MRI is being used. So similarly, it is the KV and MB with the fiducial. If you look at that, it is quick and easy, and bones and fiducial are easily visualized. But if you look at that, it is extra radiation. Basically, it is a 2D images. When you use that 3D, again 3D images, but extra radiation. When you use the CBCT, again extra radiation. And if you use that ultrasound, there is no radiation. And the radiation, it is a high imaging contrast and real time. However, that image acquisition depends upon that the contact between the patients and probe and user dependent. Training is important, and these are that one of the rationale that why that ultrasound is being used for the 4D ultrasound 4D guided image guided radiotherapy. So what is that actually that the system response for making that the real time intrafraction motion? We have in our department the Clarity Electra Clarity Autoscan transperineal ultrasound system. Basically this technique is called the transperineal ultrasound imaging technique, wherein this kind of the mechanically scanned the convex or the curved convex matrix transducer is used. So this is the probe. You can see that there are the infrared reflective marker like a tree. There are 4 markers, and this is that the base plate which will be attached to that the treatment couch. So basically this will be attached to the perineum of the prostate. Then during the treatment, and it will be acquiring the the images. So basically it will the automatically generate or creates the images by means of physical vibration, mechanical vibrations automatically within that probe. So it acquires a 75 degree, in the different angle it will acquire, and the series of 2D images will be acquired. So this is what, the architecture, how that clarity system is actually being infrastructured. So the two system will be used. One is called a clarity sim guide. Another one is a treatment guide. So you can see that both system, when you are simulating, the one system will be available having the optical system in place, and the ceiling mounted optical system and the ultrasound imaging. Similarly, the treatment room also will be having one set of ultrasound image guided and the optical system in the ceiling. And there is one more important the component called the AFC, automatic fusion and contouring workstation, which is responsible for the fusion and contouring of the prostate using with ultrasound. So once that the treatment planning is done with the TPS, the treatment, the plan will be transferred to this ultrasound imaging, whereby the fusions will take place based on that, the prostate image, that the reference volume will be the assigned, then the tolerance of the reference volume, the how much can be moved, allowable or resetted, and then it will be sent to that, the treatment room for that, the image guidance. So this is how that, the probe will be in a directly contact with that optical tracking system. It will track the position of that, the probe, which is actually attached with that, the prostate perineum. If you look at that, this is the positioning of that, the probe, which will be embedded or attached with that the prostate. So you will be able to acquire that images. You will be able to appreciate the different structures like a bladder and pubis and prostate and rectum and seminal vesicles. So this is how that the system will work. So what is the mechanism that in ultrasound, the imaging is how it is estimating that in motion? There are two ways. One is called the direct method. That means that directly the echo pattern is actually matching between that, the reference image from the search image. Another one is called based on that, this called the speckle pattern, or based on the tissue structure or anatomical feature, you'll be able to track between the reference image to the search image. Another one is the indirect method, wherein that the image segmentation based, that the motion will be estimated based on the boundaries. So these are the two methods. The clarity 3D 4D ultrasound is using that direct method. That means echo the pattern based matching reference and the test. So what are the tools required to calibrate and properties and compatibility with the harmonic imaging? So you'll be able to measure the different parameters like a uniformity and depth of penetrations and vertical distance, horizontal, axial and lateral resolutions and elevated grayscale. So all this, the image quality parameter is possible to derive from this multi-purpose phantom. So this is how when you scan that, the phantom with a transducer, you will be able to see that, the images, and you will be able to analyze that, the software. So the next important thing is that, how to calibrate it. That's very much important. So when you look at there are three important calibration procedure. One is that probe. That means the transducer probe, that the transformation matrix is important. That's how that the common coordinates is being calculated. So there are three steps. One is the probe calibrations. In the probe calibration, basically the image is a reference to that the probe. Another one is the room calibrations, wherein that the room coordinate will be relative to that the optical system. Third one is that the system the calibrations, wherein that the ultrasound imaging coordinates will be correlated with the reference of the room. So this is how that the calibrations will take place. When we started that initial that ultrasound guided the prostate the 4D or 3D, we have done that characteristics of the the both transabdominal, which will be useful for the 3D IGRT, and also we have used for the probe having that Autoscan. So what is that workflow? The clarity, if you say that this is how actually the workflow, you take the patients to that the SimCT, and then you acquire the images. First you scan the CT. Immediately after the CT scanning, just make sure that without moving the patient's ultrasound should be scanned. That ultrasound will be the reference image, and that will be sent to that the AFC, that is automatic the fusion and contouring workstation of the Clarity. So this is how. So wherein you'll be able to fuse, and then the fused images will be this is how do the registrations between that the reference simulator simulator reference image, and then acquire the images in the treatment. You compare that the three-dimensional volume of the breast, how much this is actually being moved. And during that the treatment, the console, you will be able to send the images from that the auto AFC to that the treatment room. You will be able to match that based on the 3D the prostate volume. So this is how the Autoscan 4D is being used, and you will be able to monitor that the how much the tolerance you set and use volume. You have to define that in case if the prostate moves 3 mm within that 5 seconds, you have to pass the beam, or you have to manually correct that. That is called the tracking and gating method. So how that is being done? So we have that another system called the response gating system provided by the Electa. So we said that the tolerance should be there. In case if it is exceeding that, say for example 5.2, then automatically it will stop the beam. This is what the gated beam. And this is one of that the component. This is called response gating system, responsible to gate the beam when there is when there is within that the tolerance, the beam can be out of the tolerance, beam can be passed, and within the tolerance, beam can be opened. So this is how that the beam off and beam up conditions is being triggered using that the gating control. So we have seen that what is the difference between that CBCT IGRT based the 4D ultrasound based the differences. You can see that the 2 mm 2 to 5 mm 5 to 7 mm 7 to 10 mm greater than 10 mm. In that the superior inferior directions, if you look at that 2 mm, it is more than almost 70. In case of that 4D, it is more than that, more than this one. So similarly, you will be able to see that the different the variation between that CBCT and the 4D CBCT clinical evaluation or clinical the judgment is possible whether that how that 4D.
Yeah, he joined. Okay. You can unmute Dr. Subramani. You are muted. Dr. Subramani, I think there is an unstable internet. Just will work.
So I'm muted. Am I okay now? So
yeah, we are hearing you.
Are you able to hear me?
Yes. Go ahead. Go ahead. Your PPT is not there. You have to share your PPT.
It will be there. Just
you have to share your PPT.
Is that okay, sir? Now?
Yeah, it has
come. Are you able to see me?
Yeah. Yes. In my opinion, Dr. Subramani, if you could stop your video,
so basically
there won't be any problem.
Yeah. You stop your video, just with a PPT, let us go. Yes, go ahead.
Okay.
Yeah, go ahead.
Okay.
QA, yeah.
Yeah. So we follow that, the TG protocols, say for example, the laser alignment in the room lasers, the daily positioning, the IR camera warm-up kind of things, daily. Then stability using CT scan as well as ultrasound should be within the 1 mm and quarterly. And, these are that, sorry. Are you able to see my screen?
Yeah.
Okay, so I'm coming to this, this is what, the very overview about how the ultrasound is being used in image guidance radiotherapy in terms of 3D and 4D. And if you look at that, what is the future direction or potential of the future of ultrasound imaging in radiotherapy, it's a huge potential, because that ultrasound imaging or all the imaging modalities is today, it's working towards that quantitative imaging, nothing but the imaging biomarkers, similar to the radiomics kind of things. And there are other two important the hybrid imaging, that elastography as well as the photoacoustic imaging is one of the very important modality. The elastography is a quantitative imaging. The stiffness of that the tissue properties can be evaluated. This is a kind of biomarker for the treatment response assessment is possible using an ultrasound and this elastography applications. Another one is called the photoacoustic imaging. This is hybrid imaging. Basically, the ultrasound imaging and photoacoustic imaging based on that photoelectric effect, you'll be able to explore that molecular ultrasound imaging, the potential. You'll be able to give that, the contrast enhanced based on the target material. And again, that AI is also, it's playing very important role. If you see that, the kind of the ultrasound, the AI enabled handheld ultrasound also is started coming into the market. Even for, the wearables, you'll be able to see that, the ultrasound. This is going to give a, the huge potential for the future application, not only the diagnostic and also, the therapeutic and the point of care. So as I told, it is a portable, it is a very miniaturized, you will be able to take it to that, the bedside of that, the patients. So the point of care is becoming more important for ultrasound respect. And not only that, the diagnostic and therapeutic systems, kind of that high intensity focused ultrasound kind of things also is becoming, very much, the appealing for that, the future. And obviously that automations is going to give that, the most versatile of the interoperator variability elimination. So there are various contrast agent called microbubble, from microbubble to nanobubble, nanoparticle. You will be able to see that biological and the molecular and functional imaging is possible based on the grayscale, Doppler, elastography, and quantitative imaging. And if you look at that, even for that the radiomics. There are studies like the ultrasound-based radiomics for therapy response monitoring. The locally advanced breast cancer is the multicentric studies also started taking place. So this shows that the kind of that potential. Not only that, photoacoustic imaging. This is one of the very burgeoning the research area in the developed countries. You can see that ultrasound able to take it to that LINAC. You will be able to image that microscopic, macroscopic as well as the vascular. Use that pre-treatment, during treatment, post-treatment to understand the treatment response. So coming to this summary. So the ultrasound-based IGRT is basically starting from target position verification to motion estimation and management of motion estimation and management, including the integration of ultrasound into the radiotherapy workflow provides an exciting opportunity beyond the management of inter and intrafraction, because it is low cost, high spatial, the resolution will improve that,
Please unmute yourself. Unmute first.
I think there's a bandwidth problem, Subramani. You can put off your camera so that you will have a good bandwidth when you speak.
So it's almost it's finished. Able to hear me, sir? Yeah.
Okay.
Hello.
We got it. We got it. Summary.
Yeah. Coming to this conclusion. Yeah. Coming to this conclusion, the future of ultrasound imaging is towards diagnostic for the precision medicine. So we cannot undermine that the ultrasound imaging is not important in radiation therapy. In order to have that array of technology to establish the research and also diagnostic, the diagnostic and prognostic and combined as a diagnostic, the potential are there with the ultrasound in the future. With this, I thank you for the patience listening. I would be happy to take questions. Thank you all.
Thank you. Thank you, Dr. Subramani, for your excellent presentation. Very happening in the radiation therapy. So I would like you can, if you want, you can read preparation protocol for patient positioning by this body system. Do you usually perform this?
Yes, I'm sorry, Dr. Adhikari. Tell me, I am not able to.
So it could be better if you look at the chat box. There is one question: are you use special daily bladder because of the your
Yes.
internet connection? So I know you cannot heard my voice very well. Are you listening me? No. So Dr. Subramani.
Yes, put again the question.
Not able to hear you properly.
Yeah. Okay.
Yes.
Okay. I'll put the question.
Dr. Kanchan, yeah.
To you, to everyone, please. I am putting the question here. Will you please address this question? No, it's because his internet is very unstable, I think. Are you listening me?
Just very intermittently I'm hearing. I'm sorry for the inconvenience.
Yes.
Oh, there is one question in the chat box.
Okay.
Okay, could you please look at it and answer that?
So I read you the question, Subramani, for you. Are you special daily bladder and rectum preparation protocol for patient monitoring by 4D system? Did you got the question, Subramani?
Yes, absolutely. It's a very good question.
Now answer from you.
No, because of the internet is very unstable there.
Yeah. Now able to hear me?
Yeah. We are
sorry. Yeah.
Go ahead, Subramani.
Just just to briefly tell that. We used to ask the patient to have half a liter water before 30 minutes of the simulation or treatment. So in that sense, the bladder conditions will be stable during the treatment. This is what that the protocol we follow in our department.
Yeah, and I think for the ultrasound to function and get proper images, the bladder has to be full. and that is what you are doing, that you are plenty of water you are giving, so bladder is filled completely, so you get a good ultrasound images also, and also the positioning or whatever things you want to address will be fine, right?
Yes, sir. Exactly.
Okay, Dr. Subramani, I have posted one question because
Yes.
I don't know whether you hear me very clearly or not. You will hear me very. How to address some of the limitations and challenges associated with the ultrasound imaging include bone, include the inaccessibility of tissue shielded by bone or ear, what you have shown in the earlier slide, the proneness of the imaging artifacts. How do you address it?
Yeah, that is very much important. You know, the most important thing of a limitation, if you look at that, if you state, what is the first limitation is an inter-observer variability. Apart from, you know, whatever that area you are able to access, that is, you know, different. But apart from that, if you are using that ultrasound, the major limitation is that inter-observer variability. That means the user-dependent imaging. That is the most important challenging when it comes to that ultrasound. What is the solution? The solution is that, you know, you need to have that, you know, the training program. You know, the sonographer or, you know, the technologist in radiation oncology department, not only the technologist, even, you know, the physicist, we all are supposed to understand that ultrasound image interpretation. Okay, what is actually white, what is what black, what is a gray, so where it is coming, you know, the how that, you know, the speckle pattern will be. So all this, you know, the training is important before making use of that ultrasound into the clinical practice. That is number one solution for that, you know, challenge or limitation of, you know, the intervariability. Of course, coming to this, you know, the artifact, yes, the artifact also is very, very important. If you are certain artifacts like a twinkling artifact, it helps you to identify that, you know, the kidney issues. But certain artifacts like a shadowing, certain artifact like, you know, the enhancement of the low density region. So these are all that area which need to be, you know, properly looked into that before interpreting that, you know, they're taking the call. So in the real time, you know, these are all the challenges again. Probably, you know, the AI guided. That's what it is. You know, the artificial intelligent enabled the ultrasound is in the place or in the work in progress. Probably that way, and the robotic system also is going to be in that, you know, the place. So the artificial intelligence and robotic, you know, the system combinedly will eliminate most of that in major limitation what we are facing today, including that, you know, unaccessibility of other anatomical sites such as lung and brain. So is possible. So this is only that, you know, the innovative technology will give you that, you know, how the ultrasound can be of maximum utilized in the clinical in the future to come.
So do you use some type of special gel to address the acoustic coupling for transducer and the body? How do you use it? What do you use? The same gel? What is
yes,
being
exactly.
used?
That's most important. Yeah, we use some viscous. Viscous, better viscous gel. So the transducer and the skin. So, you know, the maximum the contact is, the better the resolution. So there will be if there is a gap between that, you know, the transducer and you know, the surface of the imaging, the probably the reflective waves will not be reaching back to that, you know, the transducer, and image quality will not be there. So the image resolution. Yes, we do use that gel.
Okay, I have one more question. So can we modify the normal diagnostic ultrasound to be used to this 4D ultrasound? It's a very good question because it might be interested to most of the physicists in the developing countries. Can we modify? No.
Subramani, we lost him. Again, we lost him, I think. Just a moment, we can wait. Otherwise, we can go ahead because there's a question from Chai Hong. Can we modify from the normal diagnostic ultrasound what we use? Can this be used for this 4D guided radiotherapy techniques? Dr. Subramani, just a moment, we'll wait, or we'll have to close, I think. But there was a lot of technical issues.
No, he's back. He's back.
I'm so sorry. I'm so sorry.
No worries,
Somehow
no worries.
Okay,
It happens.
Okay, so
You are muted. You are
is,
muted. Please unmute first.
I'm unmuted.
Okay.
So you have got a question, Subramani? Can we use...
I'm sorry, sir. In between, it was I left, the connection left. Can you please repeat me again?
Yeah, that I'm repeating. Can you use the same ultrasound machine which we are using for a routine diagnostic in the diagnostic lab departments? Can this be used for this 4D ultrasound guided radiotherapy? Or do you can't use? I think there will be a lot of software and other things, modifications, other things needed. Again, we lost him, I think.
Worst life today. Anyhow. Yes, sir. I understand your question. Hello?
Yeah, go ahead.
Yeah. So, see, there are two things. Number one, you need to have that optical tracking system to be placed inside the room. Number one. Then accordingly that, the fiducial markers, the probe, embedded probe needs to be there. So that will be tracking the transducer positions, with reference to that, coordinate system of the imaging as well as the room. That is number two. Number three, that, the frame rates, probably it will be slower compared to that, the diagnostic imaging frame rates. Because if you look at that, the latest generation of ultrasound, which can go up to the 10,000 frames per second. Whereas in case of, this therapeutic range, that, because of the 2D images, slower the frame rate will not be of, that much of, little bit of, the image quality may be of degradable little bit. So probably that extra things needs to be embedded, incorporated into the ultrasound system, then probably it is possible to use. That's
Okay, I think
that's easy. So needs to be properly calibrated with each other system. That's most important.
Okay. So I think now the time is to close because there are no more questions. Let me thank Dr. Kanchan Adhikari from Nepal who has joined and moderated this webinar. First of all, my apologies because we couldn't start this webinar on time and there was some actually internet instability issue was there. But anyway, the lecture was very nice. Thanks to Dr. Kanchan Adhikari. Thanks to Dr.
Thank you.
For your excellent talk and new modality, what is being used and how it can be used. Thanks to all the participants who have participated in large number. The next, the AFOMP monthly webinar, that's the 28th monthly webinar, has been rescheduled from 8th September to 1st September, because in that month we are going to have one very important AFOMP school webinar from Professor Keel from Australia about research, and therefore there should be some gap. So we made it 1st September, and this will be on global medical physics scenario and need for interdisciplinary approach. And this will be given by me and moderated by Muhammad Jabrul Islam from Bangladesh. Time is the same. And just note that this will be 1st September. We will be, when circulating the flyer and putting on the website, the date change will be there. Further, the 22nd Asia Oceania Congress of Medical Physics 2022 is being organized in a hybrid mode, virtually as well as in person during December 10 to 12 at Taipei in Taiwan. So I know the situation what present is there, but we cannot predict how it will go. But it is a hybrid conference, and most probably it will happen in person also and through hybrid. The last date for the abstract submission has been extended to 15th August. So please do submit your abstracts. There will be some travel grants from the AFOMP, some the registration fee from the AFOMP also will be reimbursed. That things are there. Also, please do visit the AFOMP website. All the awards like Professor Madhvanath Award, the Professor Singh Chul Award, Best Paper, Best PhD, Best Radiobiology, Outstanding Medical Physics, all these awards have been announced. Applications are invited. Please look at the last date and submit your application nomination so that you become the part of AFOMP. AFOMP is doing a lot of activities, so please keep an eye on the AFOMP website. Once again, I thank Dr. Kanchan Adhikari for moderating this webinar, Dr. Subramani for giving excellent talk, Dr. Rajni Verma for helping all this website and other things and circulating, Chai Hong for as a PRC chair, she is responsible certificate and all, Jin Xians for he is a chair of the ETC, and all the participants and everyone who helped directly and indirectly for this. So we look forward for the 1st September AFOMP webinar, and then AFOMP school webinar I will be announcing soon in the same month of September, and requesting you to kindly go to the AFOMP website, see the announcement of various awards, also to the AOCMP 2022 the website, submit your abstract. If you cannot join in person, you can join virtually also. With these words, I close this today's AFOMP webinar. Stay safe, and the AFOMP is there to disseminate the knowledge. Thank you, each one of you, for your kind participation. Have a nice day. Bye-bye.
Thank you. Bye-bye.
Thank you. Thank you very much.
Thank you. Bye.
Thank you. And
Thank you very much. Have a good day.
thank you very much.